Hey everyone, sometimes it feels like you spend more time wrestling with billing codes than you do actually talking to your patients, right? Well, you are definitely not alone. Today, we're going to demystify evaluation and management coding. It's a super critical part of your practice that, let's be honest, often feels way more complicated than it needs to be. We're going to turn that confusion into confidence.
It's a huge frustration for so many of us. But here is the good news. There's actually a clear, logical framework behind it all. It's designed to capture the true value of your work. So in this explainer, we're going to break it all down piece by piece so you can code accurately, you can code efficiently, and you can do it with total confidence.
All right, here's our game plan. First, we'll decode what a patient visit really is from a coding perspective. Then, we'll dive into the 3 pillars of medical decision-making. After that, we'll do a walkthrough of the coding levels, see how it all changes when you're in the hospital, and we'll wrap up with what I think is the most crucial piece of the puzzle, your documentation. So, to get started, let's completely reframe how we think about E&M codes. Seriously, they are so much more than just numbers for billing. Think of them as a story. They tell the narrative of your patient's complexity and, just as importantly, the brainpower and cognitive effort you put into that encounter. A simple code for a common cold tells a totally different story than a complex code for a multi-system illness with a really uncertain outcome. Now, while you can code based on time, the real foundation, the bedrock of most EM codes, is what we call medical decision-making, or MDM. This is the framework that basically quantifies your thought process, all that clinical work you do. Understanding MDM is the absolute key to picking the right code every single time. So let's break it down. So how in the world do you quantify something as complex as medical decision-making? Well, it all comes down to 3 core pillars. Think of these as the foundational building blocks for every single E&M code you're ever going to use. Once you get these, I promise, the whole system just starts to click. So let's meet them. And here they are. It's really this simple. Number 1, the number and complexity of the problems you're actually dealing with. Number 2, the amount and complexity of the data you had to review and analyze. And number 3, the risk of complications to the patient. You master these 3 things, and I'm telling you, you will master EM incurring. Okay, let's dig into Pillar 1, the problems addressed. This is all about what you're actually treating. Is it just one single self-limited issue, like a minor skin rash? Or are you managing 2 stable chronic illnesses? Or maybe it's one chronic condition that's actively getting worse. The number of issues and how severe they are, that's the first piece of our puzzle. Now for Pillar 2, data. This one captures all of your detective work. Did you just order a standard lab test? Or did you have to dig through extensive outside records from another hospital? Did you have to interpret an EKG yourself? Or get the patient's history from a family member because the patient just couldn't give it? Each one of those actions adds complexity and helps justify a higher level of coding. And finally, Pillar 3, risk. This one assesses the potential for harm. And here's the key. It's not just from the disease itself, but also from your management plan. Prescribing some over-the-counter meds has a very, very different risk profile than managing prescription drugs that need toxicity monitoring or making that really high-stakes decision to hospitalize a patient. All right, so we have our 3 pillars: problems, data, and risk. Now for the fun part. Let's see how they actually work together in the real world. We're going to walk through the 4 main levels of medical decision-making for outpatient visits and see exactly how these pillars define each one. Let's start with straightforward MDM. This is your most basic level, level 1. Just think of a patient with a simple, uncomplicated insect bite. You've got one minor problem, you probably don't need any data to figure it out, and the risk from any treatment is minimal. Easy enough, right? But what happens when things get just a little more complex?
Well, for low MDM, the complexity just ticks up a notch. So maybe this time you're managing 2 minor problems, or maybe one stable chronic illness, like well-controlled hypertension. For the data part, you only need to meet the requirements for one of 2 categories, like maybe ordering a couple of unique tests. And the risk? It's low. Think prescribing physical therapy or some over-the-counter drugs.
Now we're moving up to moderate MDM, and the stakes are getting a bit higher. Notice these key phrases for the problems: exacerbation or uncertain prognosis. This isn't stable hypertension anymore. This is a patient whose stable asthma is now flaring up, or maybe someone who comes in with a new lump that needs a full workup. The data requirement goes up too, and the risk is now moderate because you're actively managing prescription drugs. And here we are at the top, high MDM. The problems here are serious. We're talking a chronic illness with a severe exacerbation or a brand new condition that poses an immediate threat to life or bodily function. And look at the data. You now have to meet the criteria in 2 of the 3 categories, not just one. The risk is high, reflecting huge decisions like sending someone to the hospital, considering emergency surgery, or even discussing end-of-life care. Okay, so we've covered the outpatient clinic pretty well. Now let's switch gears and head over to the hospital. While those core principles of MDM, problems, data, and risk, they still apply. The codes and some of the specific rules are different, and they reflect the unique demands of inpatient care. Here are the 2 most critical differences you absolutely have to remember. First, when you're coding by time in the hospital, you count your total time for the entire calendar date, not just the time you spent face-to-face. That's huge. Second, you can forget about new versus established patients. In the hospital, the codes are based on the type of service. Is it the initial visit, a subsequent visit, or the discharge? So for a patient's very first day in the hospital, their admission day, you're going to use one of these initial codes. Each one lines up with a level of MDM complexity, or, if you're coding by time, a minimum time requirement for that day. This really reflects all that comprehensive work of admitting someone, doing a deep evaluation, and coming up with a full plan of care. Then, for all your follow-up visits during that same hospital stay, you'll switch over to these subsequent care codes. The MDM levels are the same, straightforward, moderate, high, but you'll notice the time requirements are a bit lower. And that makes sense because this reflects the work of ongoing management rather than that super intensive initial workup. But what about those quick turnaround cases? You know, the patient who's admitted and discharged on the exact same day? Well, there's a special set of codes just for that scenario. When a patient is in and out on the same calendar date, these codes bundle all that work together, and they have their own specific time requirements to reflect that really condensed and intensive period of care. We've covered the what and the why. Now for maybe the most important part of all, the how. Because it doesn't matter how well you understand MDM. Your code is only as strong as the documentation that backs it up. This is where you justify your coding, tell the patient's story, and make your decisions totally bulletproof. This right here, this is such a simple but incredibly powerful tip. When you're writing down a diagnosis, don't just list it, qualify it. Is the patient's diabetes stable, or is it worsening? Is their back pain acute, or is it chronic? Just adding these small words paints a much clearer picture of the patient's complexity, and it directly justifies your decision-making. Here's a quick checklist of things that really have to be in your note. You've got to document all the meds, including the over-the-counters. If social factors are making care harder, write that down. That can count towards moderate risk. Be super specific about tests, any discussions you have with other providers, and if you use an independent historian. And listen, if you code by time, you must document the exact total time spent. That's your proof. So let's bring it all home. It really all comes back to those 3 pillars, doesn't it? The complexity of the problems, the amount of data you analyzed, and the level of risk to the patient. If you can master these 3 concepts and really let them guide your documentation, you won't just code with confidence. You'll create a medical record that truly reflects the high-quality care you're providing. You know, we focus a lot on the mechanics today, but this is about so much more than just billing. Accurate coding creates a more precise patient record. That leads to better data, and ultimately, it leads to better medicine for everyone. So the question I want to leave you with is this. Beyond just the code, how can your documentation better tell your patient's complete story?